Welcome to the Deep Dive. Today we are opening up a really critical, complex, and honestly high-stakes area of medicine. Hypertensive disorders of pregnancy, or HDP.
Yeah.
For clinicians, for researchers, and especially for expectant parents, understanding this spectrum of conditions is just absolutely vital.
It's really not an exaggeration to say that this is a global health issue that lands directly on the front line of obstetrics.
Yeah.
And the source material we're looking at today really emphasizes that HDP remains a leading cause of maternal and perinatal morbidity and mortality worldwide.
And when you look at the statistics, the gravity just sets in immediately.
Yeah.
We're talking about a condition responsible for, what, 16% of maternal deaths?
16%.
Even in developed countries. That number alone it demands immediate attention and a thorough understanding of all the protocols designed to manage it.
Absolutely. So our mission today is to provide you, the listener, with a clear and detailed clinical deep dive. We're going to go beyond just the simple definitions. We're going to explore the complex pathophysiology, the nuanced critical evaluations, which is really where astute nursing assessment saves lives, and detail the necessary medical and nursing interventions. We'll be focusing especially on treatment protocols for those acute crises.
And our goal here is to equip you with the knowledge to recognize the red flags, to understand what those critical lab markers are truly telling you, and to grasp exactly how specialized care, particularly around assessment and intervention, has to be managed moment to moment. We're focusing heavily on that clinical application because swift, accurate assessment is really the most critical tool we have in this entire disease process.
Okay, so let's unpack this. Before we can even get into the assessments and the active management, we really need to establish a clear, shared roadmap of terms.
Yeah, that's right.
The word hypertension gets used across several different conditions in pregnancy, and, mixing them up can have massive diagnostic and treatment consequences. Precision here is everything. It really is. At its foundation, we define hypertension, or HTN, simply. It's a systolic blood pressure, the SBP of 140 mmHg or greater, or a diastolic BP, the DBP, of 90 mmHg or greater.
And that's not just a one-time rating, is it?
No, that's a key point. This measurement has to be confirmed on 2 separate occasions, and they need to be separated by at least 4 hours.
And then right from there, we immediately hit what you could call the true clinical crisis level.
Yeah.
So what is that threshold and why is that line in the sand so critical?
So we define severe hypertension as a systolic BP of 160 mmHg or greater, or a diastolic of 110 or greater.
160 over 110.
Exactly. And that line 160 or 110, it's not arbitrary. It's the threshold where the risk of immediate catastrophic complications, particularly a maternal stroke, just increases exponentially.
Wow.
So when a patient sustains those readings, it requires prompt, often within minutes, IV intervention, which, we'll get into the details of later on.
So if the BP hits that severe mark, you're basically in a race against time?
You are. A race against time to protect the brain and other vital organs.
And the timing of when this hypertension appears really differentiates the conditions, right?
Precisely. If the high blood pressure was there before the pregnancy, or if it shows up really early, let's say before 20 weeks gestation, we classify that as chronic hypertension.
So it's a pre-existing condition.
It's a pre-existing condition, exactly. But it's critical to identify because these patients are at a much higher risk of developing what we call superimposed preeclampsia later on in the pregnancy.
Okay, so what if the hypertension is completely new? It appears after that 20-week marker, but nothing else seems to be wrong.
That's gestational hypertension. It's defined as new onset HTN appearing after 20 weeks gestation, and crucially, there is no other evidence of maternal organ dysfunction.
No protein in the urine, no liver issues?
Exactly. No proteinuria, no issues with the liver or kidneys. Now, this is often seen as, the mildest form, but vigilance is absolutely key. About 10 to 25% of patients with gestational hypertension will eventually progress to full-blown preeclampsia.
And just for completeness, we should probably mention the common phenomenon of white coat hypertension.
Yes, definitely. This is when the BP reads high, so that 140 over 90 or more, but only when it's measured in the clinic or the office setting.
The anxiety of being at the doctor's office.
Pretty much. And it's an important distinction to make because it really highlights the necessity of accurate measurement. If a patient is diagnosed in the clinic, asking them to check their BP at home or maybe using ambulatory monitoring helps differentiate a true condition from, an anxiety response.
And misdiagnosing that could lead to problems.
Oh, absolutely. Misdiagnosing white coat HTN as true hypertension can lead to unnecessary medication or even unnecessary interventions.
Okay, so now we move to the centerpiece of this whole discussion, preeclampsia. This is where the condition stops being just about blood vessels and really becomes about systemic failure.
It really is. Preeclampsia involves either gestational or chronic HTN combined with one or more new onset conditions. And that requirement for a new onset complication is the diagnostic gatekeeper.
What does that signify, that new onset?
It signifies that the endothelial injury, so the damage to the vessel linings caused by the high pressure, is now starting to affect entire organ systems.
So what are those specific defining new onset conditions that we need to look for?
We look at three major categories. First, and historically the classic marker, is proteinuria. Protein in the urine. This tells us there's kidney damage.
Okay.
Second is the presence of other maternal organ dysfunction. And this is a pretty broad category. It encompasses new renal impairment, elevated liver enzymes, neurological symptoms like a severe headache, or even hematologic issues like a low platelet count.
That seems like a really important expansion compared to older definitions where I think proteinuria was mandatory.
Oh, it's a huge shift.
So now it's more about the systemic dysfunction taking precedence.
Absolutely. The modern definition acknowledges that severe systemic damage can happen even without high levels of protein in the urine. And the third category is uteroplacental dysfunction.
Okay, and what does that look like?
It's most commonly observed as fetal growth restriction, FGR, or abnormal umbilical artery Doppler studies. Essentially, the placenta, which is the root of the whole problem, is starting to fail the fetus.
And the timing of this condition, when it appears, that's a major prognostic indicator, isn't it?
It is a huge one. We categorize the condition by onset. So early onset preeclampsia happens before 34 weeks gestation, and late onset is at or after 34 weeks.
And is there a difference in severity?
Generally, yes. Early onset disease is often more severe. It's related to deeper underlying placental issues, and it necessitates really intensive management because the fetus is so premature. Late onset tends to be milder, but it's also far more common.
And that brings us finally to the terrifying culmination of this entire spectrum.
Eclampsia.
Eclampsia. It's the extreme end. It's defined simply as the occurrence of tonic-clonic seizures in a patient who has been diagnosed with preeclampsia.
But there's a catch, right? Yes, and this is so important for the differential diagnosis. Those seizures cannot be attributed to any other pre-existing neurological cause, like epilepsy. It signals acute, uncontrolled cerebral involvement.
What's so fascinating here is that the physical mechanisms that lead to these most severe outcomes aren't just about blood flow. It's really about the body's delicate systems just breaking down under pressure.
Mm-hmm.
Let's start with the brain. How does elevated blood pressure actually result in a seizure?
So the primary mechanism, particularly in eclampsia, it relates to a failure in the brain's own built-in defenses. Normally, cerebral blood vessels have what's called an autoregulatory system,
Okay.
and its job is to maintain a constant blood flow despite huge fluctuations in systemic blood pressure.
So when my blood pressure spikes, my brain vessels should kind of constrict to protect the delicate capillaries from getting overwhelmed.
Exactly, that's what should happen.
Yeah.
But in severe preeclampsia, this autoregulatory mechanism fails. It just gives out, and this failure leads to hyperperfusion, a massive, uncontrolled surge of blood flow right into the cerebral circulation.
And that intense pressure must cause damage.
It does. It causes damage to the blood-brain barrier.
And when that barrier breaks down, what happens then?
Well, plasma and fluid leak out of those damaged vessels and into the surrounding brain tissue. This causes cerebral swelling, or what we call vasogenic edema.
And the edema is what causes the seizure.
The edema is what increases intracranial pressure and precipitates the seizures that are characteristic of eclampsia. And if that pressure stays uncontrolled, that severe edema can lead to microhemorrhages, infarcts, and, permanent neurological damage.
So understanding that autoregulatory failure theory is really why that rapid BP control is so vital. It's not just about the mom's overall health. It's about preventing an acute brain injury.
Precisely.
So when a patient presents, how are clinicians connecting the hypertension to this whole cascade of systemic issues? What are the key diagnostic markers they're using to confirm it's actually preeclampsia?
Clinically, the diagnosis requires that HTN combine with specific signs. So we look for the symptoms the patient is reporting.
Things they can feel.
Exactly. A persistent, often unrelenting headache. Visual changes like blurry vision, seeing flashing lights, or scotoma's blind spots. Or a sudden severe pain in the right upper quadrant or epigastric area. These symptoms are often the first subjective flags that the patient's organs are under serious duress.
And then the confirmation comes from the labs and the complications that result from it.
Yes. We look for HTM plus abnormal labs, elevated urine protein ratios, elevated uric acid, which is an older but still useful marker or evidence of the most urgent complication, HELLP syndrome.
Which we'll get to.
We will. And the diagnosis is also confirmed if the hypertension leads directly to complications like pulmonary edema, renal failure, or that rare but severe neurological issue known as PRES.
Okay, let's pull the lens closer on that deadly acronym you just mentioned, HELLP syndrome. I mean, this acronym is basically the clinical summation of multi-system failure.
It is. And recognizing HELP is paramount because it requires immediate stabilization and delivery, often regardless of the gestational age. We have to break down exactly what each letter signifies.
Okay, let's start with the H.
H is for hemolysis. This is the non-immune destruction of red blood cells as they get sheared and damaged, passing through severely constricted microvasculature.
And you can see that on a lab test.
Oh, yes. Clinically, we see schistocytes, these fragmented red blood cells, on a peripheral blood smear, and often elevated bilirubin and LDH.
Okay, then we have EL.
EL stands for elevated liver enzymes. Specifically, the AST and ALT levels are significantly elevated, usually greater than twice the upper limit of normal. This indicates severe hepatocellular necrosis and damage.
And that's why patients report that intense epigastric pain.
That's exactly why. The liver capsule, called Glusson's capsule, is being stretched by swelling and microhemorrhages inside the liver itself. That's the source of the pain.
And finally, LP.
LP is for low platelets. Thrombocytopenia. This is defined typically as a platelet count below 100,000 per microliter, and it indicates a systemic consumption of platelets.
Why are they being consumed?
It's due to the severe endothelial damage and widespread microclotting happening all over the body. And those low platelets put the patient at an extreme risk for hemorrhage, especially if delivery or any surgical intervention is needed.
That's a terrifying combination of conditions, and it demands immediate intervention.
But HELLP isn't the only severe outcome. What are some of the other critical complications that can arise from uncontrolled HDP?
Well, because HDP damages the systemic vasculature, the complications can affect virtually every single organ. We see acute outcomes like pulmonary edema from fluid overload and capillary leak, acute renal failure, and neurological catastrophes like a hemorrhagic stroke or a myocardial infarction, an MI.
You also mentioned PRES, that's posterior reversible encephalopathy syndrome. What exactly is that?
So PRES is a neurological disorder that manifests very similarly to eclampsia, often with seizures, visual changes, and headache. But it's specifically characterized by distinct findings on an MRI, primarily edema in the posterior regions of the brain.
Hence reversible. The good news is that it often is, yes. Once the blood pressure is controlled and the underlying insult is removed. But recognizing it is critical because it confirms that acute cerebral dysfunction we were talking about earlier.
Other risks.
Other acute risks include a life-threatening hepatic hematoma or even rupture stemming from severe HELLP-related liver damage and, sadly, maternal death.
A really crucial teaching point here is that the risk doesn't just end with delivery. The postpartum period is deceptively dangerous.
It is, and this often surprises patients and even some newer clinicians. We see a high incidence of postpartum hypertension and preeclampsia. The peak incidence is typically 3 to 6 days postpartum.
Why that specific window? I mean, what is the mechanical cause of that spike?
It's directly linked to the massive hemodynamic shift that's happening in the immediate puerperium. After delivery, the large volume of extracellular fluid that was accumulated during pregnancy begins to rapidly mobilize and shift back into the circulation.
So the body is flooded with fluid.
Exactly. This sudden influx of fluid stresses the already damaged endothelium and cardiovascular system, and it often leads to a spike in blood pressure. So nursing vigilance regarding fluid balance is just paramount during this time.
And eclampsia can happen even after the placenta is out.
Oh, absolutely. The data confirms that approximately 25% of eclamptic seizures occur in the first 2 days postpartum.
Wow.
This means postpartum nursing assessment has to maintain the exact same hypervigilance for neurological symptoms, headaches, gotomas, that we apply antepartum. The danger doesn't just magically vanish when the umbilical cord is cut.
So, to summarize for the listener, what are the adverse outcomes for the baby and for the future health of the mother?
For the infant, the condition places them at risk for complications like being small for gestational age or suffering intrauterine growth restriction, placental abruption, which is a life-threatening separation of the placenta, preterm birth, increased rates of C-section, and unfortunately, stillbirth.
And for the mother's future?
For the mother, the diagnosis has serious long-term consequences. HDP significantly increases her future lifetime risk of cardiovascular disease, hypertension, diabetes, and increased rates of short-term postpartum mood disorders, especially if her infant requires a stay in the NICU. It's a diagnosis that truly requires lifelong attention.
Okay, this is where we shift focus entirely to the clinical trenches. The evaluation protocols for HDP are so meticulously defined because timely intervention hinges entirely on accurate assessment. This is really the core role of the nursing staff in managing these high-risk patients.
Absolutely.
Let's start with the seemingly simple task of taking a blood pressure.
Even the basics have nuances that can completely alter a diagnosis. The single most important rule that the source material highlights is this. If the BP reading is higher on one arm than the other, the clinician must always use the higher reading for all documentation and all decision-making.
Why is that rule so rigid? Is it just about capturing the worst-case scenario?
It's about vascular pathology. A discrepancy between arms can indicate underlying vascular disease or anatomical variations, but clinically, the higher reading represents the maximum systemic pressure load being experienced by the patient's organs.
So you have to treat to the highest number.
You must manage the highest measured pressure to prevent those severe events like a stroke, and the technique has to be standardized too. Appropriate cuff size, patient seated upright, arms supported at heart level. Inaccurate BP measurements lead to delayed or incorrect interventions.
Moving beyond the number itself, certain patient complaints are immediate sirens. What are the key signs and symptoms that demand urgent, immediate investigation?
Clinicians have to be laser-focused on neurological and upper abdominal symptoms, which the sources call starred signs.
Starred signs.
Headache and visual changes are critical because they are predictive of eclampsia in a patient who already has preeclampsia. They signal that cerebral autoregulation is failing and that edema is building.
So if a patient with preeclampsia calls and says, I have a new, really bad headache.
Immediate assessment and intervention for seizure prophylaxis are indicated right away.
And what are the symptom that's linked most closely to that nightmare scenario, HELLP syndrome?
That is epigastric pain or pain in the right upper quadrant, the RUQ. As we discussed, this pain is the result of that hepatic edema causing the stretching of Glisson's capsule.
So if a preeclamptic patient reports this,
The assessment sequence has to jump immediately to checking for HELP. You're ordering a CBC, liver enzymes, and preparing for stabilization.
we also look for physical manifestations on the skin, specifically petechiae. What are we looking for and what does it tell us?
Petechiae are round, pinpoint spots that appear under the skin, and they result from small vessel bleeding. A key thing is they are non-blanching.
They don't disappear when you press on them.
Exactly. Their presence signals severe thrombocytopenia or coagulopathy. The LP component of HELP is causing this microvascular bleeding. A rapid visual check for petechiae or ecchymosis or bleeding gums is a crucial step in assessing the bleeding risk in a patient with low platelets.
Okay, now let's transition into the internal story that the lab evaluation tells us. A deep dive into the significance of these values is just essential for clinical decision-making. Let's start with the CBC.
So the complete blood count, the CBC, gives us our platelet count. That's our immediate marker for HLLP and for bleeding risk. But beyond that, we're looking for signs of hemolysis, specifically a low hemoglobin or hematocrit that's out of proportion to any visible bleeding, and potentially an increase in other serum markers of hemolysis.
Next, the renal panel. And let's focus on creatinine. This one requires some pregnancy context, doesn't it?
It absolutely does. In a healthy, non-pregnant patient, we're looking for a low creatinine, but normally pregnancy increases the glomerular filtration rate by 30 to 50%. So as a result, creatinine levels are actually decreased in a normal pregnancy.
So if a patient is preeclamptic, what does an elevated creatinine reading signify?
Even a high normal or slightly elevated creatinine, say over 0.8 milli-GDL, is highly alarming. It suggests either acute kidney injury from vasoconstriction or hemoconcentration, which is severe volume contraction.
So what's the threshold?
The threshold for defining renal dysfunction in pregnancy is generally a serum creatinine concentration of 1.1 milli-GDL or greater, or a doubling of their baseline. This is a critical marker that the kidney's filtering units are being severely damaged.
If the condition is worsening, we then have to look at the coagulation panel, INR, APTT, and fibrinogen. This is where DIC becomes a frightening possibility.
Disseminated intravascular coagulopathy, or DIC, is a paradoxical condition. It's widespread clotting happening at the same time as a massive risk of bleeding.
How does that even work?
Well, we check the INR and AKTT. Elevated levels signal that the clotting cascade's taking longer than normal because the clotting factors are being used up or inactivated, but the most specific marker for that consumption is fibrinogen.
And how does fibrinogen behave in DIC?
Fibrinogen is a key component of the clot itself. In DIC, it is rapidly consumed and drops dramatically, so a low fibrinogen level is highly predictive of adverse maternal outcomes. This whole constellation of lab abnormalities, the elevated ARNAPT and the decreased fibrinogen, can be caused by a severe abruption, or HLLP, and it signals that the patient's entire hemostatic system is just collapsing.
Let's move to the liver panel, which confirms the EL in HELLP. We need to distinguish between what's indicative of damage and what's actually normal in pregnancy.
Right, so ALT and AST are the main indicators of hepatocellular injury. Elevated levels, usually exceeding 70 IUL, confirm that liver cell damage that's characteristic of HELP. Bilirubin may also rise as a byproduct of the hemolysis, that red blood cell destruction.
And what about the confusingly high alkaline phosphatase, or ALP?
ALP is fascinating because it is always elevated in pregnant patients, sometimes up to 4 times the non-pregnant normal range.
Why is that?
Because the placenta produces large amounts of it. Therefore, an elevated ALP alone does not diagnose preeclampsia or liver injury. Clinicians have to rely on the ALT and AST levels to assess true hepatic damage. This is a vital piece of context that prevents unnecessary panic over a lab value that is physiologically expected.
We also look at albumin and LDH.
Right. Albumin, which is a key plasma protein, often decreases in preeclampsia due to that capillary leak and proteinuria. And LDH, lactate dehydrogenase, is a non-specific enzyme that's released from damaged tissue, particularly red blood cells and the liver. So a high LDH is a general marker of tissue damage, and it confirms hemolysis, further supporting a HELLP diagnosis.
Finally, the measure of kidney damage,
The
the urine protein creatinine ratio, or PCR.
PCR gives us a rapid, accurate assessment of proteinuria. Significant proteinuria is defined as a ratio of 30 millimole or greater. This confirms that the glomerular filtering units of the kidney are damaged and leaking large amounts of protein.
And this leads to a really crucial clinical efficiency insight. Once the diagnosis is confirmed by a positive PCR, we don't need to repeat it. Why is that?
This is so key for management efficiency and for reducing resource use. Once the PCR confirms the diagnosis of preeclampsia, the source material explicitly states the test does not need to be repeated.
Why not?
Because the degree or the magnitude of the proteinuria has no prognostic impact on the worsening of the condition or on perinatal outcomes.
So it doesn't matter if the number is a little high or extremely high.
Exactly. Whether the protein level is moderate or extreme, the management protocol remains the same. You monitor the patient clinically for severe features, not just for higher protein numbers. This is a major change from older protocols that relied on cumbersome 24-hour urine collections.
So we've moved through the meticulous assessment, we've confirmed the severity of the diagnosis, and now we shift gears entirely into active management. And this starts before they even reach the hospital door, with effective patient teaching.
Patient teaching is maybe the most critical nursing intervention for patients being managed outside of the hospital for chronic or gestational hypertension. We have to counsel patients thoroughly on home BP monitoring. And this shouldn't just be passive advice, it needs to be detailed instruction.
What are the absolute must-include elements of that counseling?
First, proper technique. Using a validated cuff, one that fits properly, ideally on the same arm every single time. Second, frequency. Instructing them to check their BP 2 to 3 times per day. And most critically, we have to establish clear, actionable parameters for when they must immediately contact their care team or present to the hospital.
And what's that life-saving instruction they absolutely need to internalize?
The instruction is crystal clear. If the blood pressure reaches a sustained severe hypertension, that's a blood pressure greater than a 160 over 110, they must present to the hospital immediately.
No waiting.
No waiting. Similarly, the onset of those severe symptoms, a new persistent headache that Tylenol doesn't touch, acute visual changes, or that added gastric pain that warrants immediate presentation even if the BP reading they just took at home was marginally lower. Delaying presentation can mean the difference between a controlled situation and a catastrophic stroke or seizure.
So, once they're in the hospital, let's detail the pharmaceutical interventions. Starting with the oral medications used for ongoing maintenance therapy in the antepartum period.
Right. These are used to manage the mild to moderate HTN to keep the pressures below that severe threshold of 106/110. The mainstays are labetalol or Trandate. This is a combined alpha and beta blocker, often the first-line choice. Dosing ranges from 100 to 400 milligrams, taken orally up to 3 times a day.
And there's a clinical caveat with labetalol.
Right. There is, a crucial one. It should be used with caution or avoided entirely in patients with a history of asthma or bradycardia because the beta blockade component can make those conditions worse.
Okay, what else is in the toolkit?
Bifidopin SR or Adalat XL. This is a sustained-release calcium channel blocker. It's typically dosed at 20 to 60 milligrams, taken orally once or twice a day. And then there's methyl-dopa, Aldamit. It's an older, centrally acting agent. It's often preferred for long-term chronic management and has a very established safety profile. Dosed at 250 to 500 milligrams 2 to 4 times a day.
But it's not as potent.
Right. Its efficacy is often a bit slower and less potent than labetalol or nifedipine.
So these medications buy time. But when the patient is in crisis, hitting that 160 over 110 threshold, the management flips to rapid IV interventions to prevent immediate maternal morbidity. What are the key FAV protocols?
The goal of IV management is not to normalize the blood pressure completely. That can actually compromise placental perfusion.
Right.
The goal is to quickly reduce the pressure to a safer subcrisis range, typically below 150 over 100. And we use IV labetalol, administered in incremental boluses, 20 milligrams initially, then 40 milligrams, then 80 milligrams every 30 minutes, or as a continuous infusion.
You have to watch the baby during this?
Absolutely. Continuous fetal heart rate monitoring is essential because too rapid a drop in the mom's BP can compromise fetal oxygenation.
What are the other IV options?
Afetolazine or apresilene, it's a peripheral vasodilator. Dosing is typically 5 to 10 milligram IV every 30 minutes. A key side effect to monitor with hydralazine is maternal headache and reflex tachycardia. And then there's nifedipine IR, immediate release.
So that's not IV.
Correct. It's 5 to 10 milligram given orally, not intravenously, every 30 minutes. The immediate release formulation ensures a rapid onset, making it a viable option for acute management if IV access is delayed, though you have to be cautious about the risk of severe hypotension.
It's important for the listener to understand these are rigid protocols with immediate reassessment after every single dose. But as we mentioned earlier, there is one medication that stands completely alone in treating HDP, and that is magnesium sulfate. It's not an antihypertensive, correct?
That is absolutely correct. MgSO4 is the cornerstone of therapy, but its primary function is not to lower blood pressure. It has a very minimal antihypertensive effect. Its role is as a central nervous system depressant and a seizure prophylactic agent.
So it works on the brain, not the blood vessels.
Exactly. It stabilizes neuronal membranes, reducing neuromuscular irritability and raising the seizure threshold.
Given its high alert status, what are the specific clinical indications that necessitate using MgSO4 even before a seizure has happened?
The indications are quite broad because we are trying to prevent a neurological catastrophe. It's indicated for 1, the immediate treatment of eclampsia, so stopping an active seizure. 2, any patient diagnosed with severe preeclampsia, so BP over 160 or 110, whether or not they have symptoms.
And what else?
Any patient with preeclampsia who is showing symptoms predictive of eclampsia, that persistent headache, the visual changes, hyperreflexia. And finally, the presence of other severe features like thrombocytopenia, progressive renal insufficiency, or significantly elevated liver enzymes, the HELLP components.
Because those indicate severe distress.
Yes, they indicate severe multi-system distress and a very high seizure risk.
This drug is high risk, high reward. We need to detail the dosing and, most importantly, the monitoring requirements.
The primary administration is the IV protocol. This involves a rapid 4-gram IV loading dose administered over 15 to 30 minutes, and that's followed by a continuous 1 gram per hour maintenance infusion. This protocol quickly gets you to therapeutic serum levels.
And the monitoring. What signs tell you the drug is working, or, more critically, becoming toxic?
Therapeutic levels range from 4.8 to 8.4 milli-GDL. Nursing monitoring is absolutely critical, usually performed every single hour. We look for 4 main things.
Okay.
1, patellar deep tendon reflexes, or DTRs. The loss of DTRs is often the very first clinical sign of rising magnesium toxicity, and it usually happens at serum levels around 10 milli-GDL.
So checking the knee-jerk reflex is a safety check.
It's a vital safety check. 2nd is respiratory rate. Magnesium is a respiratory depressant. A drop in respiratory rate below 12 breaths per minute signals severe toxicity and imminent respiratory arrest.
What's the 3rd check?
Urine output. Magnesium is excreted solely by the kidneys. If urine output drops below 30 milliliters per hour, magnesium levels will rapidly climb to the toxic range. And 4th is level of consciousness. Signs of lethargy or somnolence indicate the CNS depression is becoming too pronounced.
This sounds like constant meticulous observation is mandatory. And if a patient does exhibit signs of severe toxicity, respiratory depression, or loss of DTRs, there is an immediate life-saving antidote, isn't there?
Yes. Every clinical unit using MGSO4 must have calcium gluconate immediately available at the bedside.
The antidote.
It's the direct antidote. It reverses the neuromuscular and respiratory depressant effects of hypermagnesemia. Administering 1 gram of calcium gluconate IV slowly over about 3 minutes can counteract toxicity rapidly while the MGSO4 infusion is halted. Understanding the safety net is fundamental to safe administration.
That detail is exactly what makes this a true deep dive. The management isn't just starting the infusion, it's the intense, continuous monitoring and the preparedness for toxicity.
It connects every single part of the care plan: the pathology, the pharmaceutical intervention, and the high-level nursing assessment required to ensure maternal safety.
This deep dive has covered a massive amount of crucial ground. I mean, we've moved from precise definitions to the underlying mechanism of cerebral injury, and then detailed the acute, nuanced assessment required in the clinical setting.
Yeah, the key takeaways for the learner really have to focus on that clinical recognition. Remember that those subjective symptoms, the severe epigastric pain that's linked to HELLP, the persistent headache and visual changes signaling an imminent eclampsia, those are the patient's early warning system.
And understanding the role of magnesium.
And understanding that magnesium sulfate is a dedicated CNS stabilizer, not a BP med, and that it requires meticulous monitoring of DTRs, respirations, and urine output. That is the difference between safe and unsafe management in a severe case.
And we have to always remember that postpartum risk window, that 3 to 6 day spike, where the fluid shift can put the body right back into crisis mode. The assessment doesn't stop just because the baby is born.
Exactly. And as we close, I want to leave you with a final provocative thought that brings us full circle to the lifelong implications of this diagnosis. We tend to focus so intensely on the immediate risks, the set sections, the abruption, the NICU stay, but HDP is a powerful predictor of the mother's long-term health.
So what specifically should the patient be discussing with their primary care provider for years and years to come?
The diagnosis of HDP acts as a profound cardiovascular stress test that informs future health. We know from the data that these mothers carry a significantly increased future risk of developing chronic hypertension, coronary artery disease, and type 2 diabetes.
So it unmasks a predisposition.
It unmasks a predisposition. This knowledge underscores the absolute necessity of lifelong follow-up care. HDP isn't just an obstetrical diagnosis. It's a critical early marker for future metabolic and cardiovascular challenges, demanding proactive screening and lifestyle management for decades. And that comprehensive perspective is the ultimate application of the knowledge we've discussed today.